Good morning to the people from the United States and my colleagues in Myanmar and India. Good evening. Today is a very auspicious day. It's a good opportunity for us, Myanmar GI and Liver Foundation, to work together with the Daily Liver Foundation and the INED education system. Because the COVID-19 outbreak is pandemic and the rampaging all over the whole world, I think it is entirely appropriate to talk about the COVID-19 from different perspectives. I'll be moderating the sessions together with Professor Anil Arora from of the Saigon Hospital and the Daily Foundation. There are 4 speakers, 2 from Myanmar and 2 from United States. I will introduce 2 speakers from Myanmar, and Professor Anil Arora will introduce 2 speakers from the United States. That will be followed by the Q&A sessions. Because of the time limitations, I would like to request all the speakers not to exceed 15 to 20 minutes, because in Myanmar we have night curfew beginning from the 10 p.m. So we must we should able to finish the latest by 8:45 p.m. and so that we could have enough time to go back home. So the topics and the speakers are Professor Winheim from Myanmar will be talking on the pathology of COVID-19 disease. Then Professor Chosothorn will talk on the diagnosis of COVID-19, and Professor Sanjay will talk about the liver and GI manifestations of the COVID-19, and Professor Gish will be on the current perspectives of the COVID-19. So as I have noted, we'll begin with the first speaker from Myanmar. So I'll introduce Professor Winheim. Professor Winheim is the head of Department of Hepatology of the Liver Department of Hepatology, University of Medicine 1, and the Yangon Specialty Hospital. He's been very active in the field of hepatology and in all the educational activities as well as social activities, reaching out to the people in the district and actively involved in the educational activities. So without much ado, I would like to request Professor Winheim to come up and talk about the pathology of the COVID-19. Professor Winheim, please.
For your kind introduction. Actually, my topic is pathology of the COVID-19. Good evening, everybody. Good evening, all my senior and junior colleagues. I will bring my presentation with online sharing. So my topic is pathology of the COVID-19. Let me say a little bit about the COVID-19. Actually, COVID-19 is the coronavirus disease 2019. It's an infectious disease causing severe acute respiratory syndrome. The causative agent is severe acute respiratory syndrome, coronavirus type 2. We call it SARS-CoV-2. Actually, the virus is initially known as 2019 novel coronavirus. We call it nCoV 2019. So you have to clear about the disease is COVID-19. The virus is SARS-CoV-2. This is an illustrated diagram of SARS-CoV-2 and COVID-19. This is an electron microscopy of the SARS-CoV-2. So you know, they are the beta coronaviruses. We have 3 beta coronaviruses. MERS-CoV, SARS-CoV, and SARS-CoV-2. MERS-CoV is the Middle East Respiratory Syndrome coronavirus. It is initiated from the host, reservoir host from bat, and then intermediate host is dromedary. The receptors for this virus is CD26 and DPP4. The SARS-CoV, severe acute respiratory syndrome coronavirus, is a kind of beta coronavirus as well. The reservoir host is bat, and then intermediate host is civet. The receptor is ACE2 receptor. And SARS-CoV-2 is a severe acute respiratory syndrome coronavirus 2. This is a kind of beta coronavirus. Reservoir host is the bat as well, but we are not sure about the intermediate host. There are so many concepts about the intermediate host, like a snake or other animals. The receptor is similar, ACE2 receptor. The virus started from local seafood market known to sell live and freshly slaughtered hunted animals, the bat, snake, pangolins, etc. The SARS transmitted from horseshoe bat, then to civet cat, and then to humans. So this is a close-up view of the SARS-CoV-2. You can see the virus has spike glycoprotein S, membrane protein M, nucleoprotein N, and genomic RNA, envelope small membrane protein E, as well as heme agglutinin esterase. So this is a illustrated diagram of the same coronavirus protein. So the first case of the virus is discovered in Wuhan, China, in December 2000. It spreads globally and gradually. Now the outbreak was recognized as a pandemic on 11 March 2020 by WHO. Actually, COVID-19 is a respiratory disease. It has extensive overlap with the other respiratory disease like influenza, rhinoviruses, whooping cough, atypical pneumonia, etc. So the World Organization, WHO, in studying, it is called this illness as the novel coronavirus infected pneumonia, NCIP. On 11 February 2020, the WHO officially renamed the clinical condition COVID-19. Is it a shortening of the coronavirus disease 19? So this is a replication of the coronaviruses. When the coronaviruses attach to the cell membrane through the receptor, their S protein binds to the cell surface molecule, such as metalloproteinase aminopeptidase, and the viruses also HE protein. They also bind to N-acetylneuraminidase neuraminidase acid that serves as a co-receptor. So far, it is not clear whether the virus entered into the host cells by fusion or the receptor-mediated endocytosis. Subsequently, the virus is acidified by the proton pumps, and the virus have to escape destruction and transport to the lysozyme. The coronavirus has a single positive strand RNA genome, and they can directly produce their proteins and new genomes in cytoplasm. At first, the virus synthesizes its RNA polymerase that only recognizes and produces viral RNAs. This enzyme synthesizes the minus strand using the positive strand as a template. Subsequently, the negative strand serves as a template to supply smaller subgenomic RNAs, which is used to synthesize all other proteins. Furthermore, the negative strand serves for the replication of the new positive strand RNA genome. The protein N binds the genomic RNA, and the protein M is integrated into the membrane of the endoplasmic reticulum, like the envelope proteins S and He. After binding, assemble nucleocapsid protein with a helical twisted RNA parts to the ER lumen and are encased with its membrane. Finally, the viral progeny was finally transported by the Golgi vesicles to the cell membrane and are cytosed into the extracellular spaces. So this is the same diagram, the attachment and entry of the virus SARS-CoV-2 by with the ACE2 receptor, and fusion and encoding, and then genomic RNA is released, and then translation of the ORF1A and 1B, and replication, translation, and finally, it is assembled in the Golgi breeders and exocytosed through the vesicles and released out of the cells. The spike surface glycoprotein of the virus binds to the host via the receptor binding domains of the angiotensin converting enzyme, which is most abundant in type 2 alveolar cells. So the main reasons the respiratory tract is involved in the COVID-19 infection is due to abundance of these ACE2 receptors in these alveolar cells. After a series of immunological reaction and cytokine storm, there is a diffuse bilateral alveolar damage, desquamation, hyaline formation, and finally leads to the ARDS. So you can see a lot of ACE2 receptor in the brain, throat, heart, lungs, intestine, etc., the kidney, etc., but spleen and the liver. The SARS-CoV-2 has a lot of reaction causing a metabolic activity, inflammation, stimulation of the T cells, macrophages, cytokine storm like interleukin-6, interleukin-7, interleukin-22, CACL10, etc. And then that causes inflammation of the vessels, heart of coronary arteries, endothelial cells, microvascular dysfunction, etc. that involve many organs, and finally it becomes a multi-organ disease nowadays. So after SARS-CoV attached to the target cell, the viral releases RNA into the cells and initiating replication of the virus, which further disseminate to infect more other cells. SARS-CoV-2 produces several virulence factors that promote shedding of the new virions from host cells and inhibit immune response. So you can see a lot of reaction, SARS-CoV-2 entry and replication, antigen presentation, cellular immunity, humoral immunity that involve a lot of cytokine storms, and then inflammation and destruction of the many organs. So mechanism of cardiac injury in COVID-19 is probably direct cardiac cells injury by the virus, likely through the ACE2 mechanism. And another one is pro-inflammatory cytokines such as a result of virus infection, immune receptor response can cause the multi-organ failure in DIC. Severe hypoxia from acute respiratory damage caused by the virus may result in oxidative stress, myocardial injury, and that increased myocardial oxygen demand in the presence of the severe hypoxia due to acute lung injury. Lymphopenia is commonly seen in patients who are critically ill, suggesting that SARS-CoV-2 viral particles can invade lymphocytes and cause target destruction of the cells. So actually, the R0, this is a basis production number of SARS-CoV-2, has estimated between 2.2 and 3.28. That means one infected individual on average causes 2 to 3 new infections and spread to the other persons. The incubation period of COVID-19 was calculated to be 5 to 14 days in adults, but in pediatric population, it is shorter. So actually transmission is spread from person to person by respiratory droplets. Now some say that this is the aerosol transmission in the air, and sometimes in close contact with other persons when infected persons cough or sneezes. SARS-CoV-2 also has detected in respiratory, fecal, and blood specimens. So they can be transmitted through the droplets as well as fecal oral route as well as blood specimens. So another route implicated in transmission of the SARS-CoV-2 include contact with contaminated fomites due to persistence of the virus on the surfaces. You can see the virus live in 3 hours, 3 days in the air, 4 hours on the copper, 24 hours on the cardboard, 72 hours on stainless steels, and 72 hours on the plastics. So it can live long and spread to the other persons. So most people infected with the COVID-19 virus will experience mild to moderate respiratory illness and recover without requiring special treatment. So this is a good news for the COVID-19, but older people and others with the underlying medical problems like cardiovascular disease, diabetes, chronic respiratory disease, cancers, they have a more serious illnesses. So COVID-19 typically present with systemic or respiratory manifestation, but some individuals and can act as silent carriers. So this is very important because it was spread asymptomatic persons from asymptomatic person to other persons, and the spread is globally very, very damaging to the other persons. So some also experience mild gastrointestinal or cardiovascular symptoms. They are much less common. So you can see there is a viral response phase or host inflammatory phase. And in the viral response, there is a lymphopenia, which occurs in about 5 days. And then abnormal chest imaging, which occurs in about 10 days. And then there is a finally host response phase, that is elevated inflammatory markers, cardiac markers, and finally damaging multi-organ failure. So the spectrum of disease severity is mild illness with the reported in 81% of the patients, very severe illness, hypoxemia, more than 50% of lung involvement on imaging within 24 to 40 hours, and 14%, we call it pneumonia or severe pneumonia, and very critical diseases like respiratory failure cases, shock, multi-organ dysfunction syndrome, which was reported only in 5% of the cases. ARDS, sepsis, septic shock, and myocardial infarction will occur in this type of patients. The overall case mortality was between 2.3 to 5%. It is not high, but the transmission is very rapid and very expensive. So there are a lot of death cases nowadays, especially in Asia as well as Europe countries and US. So in conclusion, SARS-CoV-2 is a highly infectious coronavirus causing fatal diseases. There is a many complex immune reactions leading to multi-organ failure. And the outcome of infection is unpredictable in most severe and elderly patients with comorbid diseases. So knowing pathophysiology of this infection may help in future therapy of the diseases. Thank you very much for kind attention. I will bring presentation back to moderators. Thank you.
Thank you, Professor Winine, for your comprehensive review of the pathology of disease. So the next speaker is Professor Chosotun. And
okay, thank you.
Can I introduce Professor Chosotun? He is currently the chairman of the president of the Myanmar GI and Liver Foundation. He is a senior patron of the Myanmar GI and Liver Association, and also a very active, very enthusiastic, and he's involved in almost all the educational activities and initiated a lot of outreach program to the people. So we were very happy when Professor Anil offered us to get involved in the COVID-19 perspectives, and Professor Chosotun willingly took the title of Diagnosis of COVID-19. So without much ado, can I request Professor Chosurun to start your presentation? And the next two speakers will be from the US, and the co-moderator, co-chair, Professor Anilra, will introduce. So Professor Anilra, could you introduce after the end of this Professor Chosurun presentation, the next two US speakers?
Thank you, Siaji. Thank you, Siaji, for your kind introduction. Hello, good evening, and good morning, everybody. Today, I will be presenting on the diagnosis of COVID-19. I have no conflict of interest for this presentation. So I will be presenting my section in about 15 minutes under these headings. So diagnostic testing is possibly the only efficient way to monitor the spread of SARS-CoV-2 in time and space, enabling policymakers and healthcare workers to track and mitigate the outbreak of COVID-19. Not only the diagnosis, the diagnostic markers are also useful for the staging, prognostication, and therapeutic monitoring. And the data we know up till now is just the tip of the iceberg. For a little introduction, there's an outbreak of novel coronavirus in the end of 2019. After about 2 weeks, the Chinese scientists made a full genome sequence of the coronavirus. And then it was known that it was most similar to SARS than the MERS. So it was called SARS-CoV-2. So I will present you on the detection of SARS-CoV-2. So there are many detection methods, including the virus detection or the immune response of the host. There are so many samples we can take, and I will deal with it later. There are two things, the viral nucleic acid diagnostic test using our usual quantitative real-time PCR, and the new ones like isothermal amplifications. There are hybrid methods, and we usually sometimes use DNA sequencing for the epidemiological studies. For the viral antigen, we can use antigenic tests like lateral flow assays, the point of care assays, and ELISA also. For the immune response, we can use the blood for specific antibodies, and we use serological tests for that. So this is the Santa Clara County outbreak, where they do a genomic sequencing to track the source of the spread of the virus and see the travel moves from the Europe in the US. So these are the assays, various RT-PCRs using different genome primers. And then you can see in Japan, they are using nested more than one genomic region. So if I have to carry on the comparison between the molecular diagnostics, our standard quantitative RT-PCR is very sensitive and specific. And the only thing is that it takes a long time and it's very expensive. The new ones, the point of care test, we had a nearly similar sensitivity and specificity, but lesser cost and quicker turnaround time. We even, with this lateral flow assays, we have very quick results and much cheaper than the previous ones. And the specimen collection we are using now is nasopharyngeal and oropharyngeal, which we need very skilled laboratory personnel, which they should wear protective equipment, or otherwise it is very hazardous for the medical workers. Now the Yale researchers has come up with a new source or where we can use saliva, test it from the saliva. So there is less contamination to the healthcare workers. It is very easy to take the specimen. If we look at the source of the specimen and the positive yield, you can see the lower lungs aspirates have the best results with nasopharyngeal better than the oropharyngeal. We can also take samples from the feces also. And there are new methods which can directly, without any preparation, we can test it from the swab extracts. These are the rapid diagnostic tests. And the Germans are using the mini pool method where we can test a lot of people at the same section. One exciting thing is the US approved the first CRISPR coronavirus test. This is compared to the RT-PCR, they don't use the heat method, they use enzymes. And the protein, in this case, the Cas13 with the nucleus activity. And with the lateral flow strips, it is very easy to operate the point of care test, and then this is much cheaper. According to them, it will cost less than $1 per test, which is very exciting. Another thing is the antigen antibody test, and this is a illustrated diagram cartoon of antigen and the antibody IgM and IgG responses, where with this principle, we use these ELISA kits for the viral antigen or the host antibody kit. The point of, so there are also a point of care test, which is very easy to operate using just a drop of blood, like we test in the hepatitis B and C. And these are the examples showing IgM, IgG, and control. Another exciting diagnostic method is identification of post-response biomarkers. Different diseases have different biomarkers. You can see the COVID-19 and influenza, we got different post-response biomarkers. Not only we can differentiate between the infections, but only for prognostication, we can use this method. And it's a very exciting method. Next, I will go on to the diagnosis of the disease, which is COVID-19. Professor Winai has already talking about this course of the disease and the severity, so I will just touch the clinical portion. I would like to emphasize that the initial portion of the infection is the viral replicating. The viral dampen our innate immune response, so the viral can replicate in the early section. And then later on, the adaptive immunity comes in, and this is where the dysregulated immune response can cause severity of the disease and death, which is about, as Professor Winai, 2 to 3%. You see, the 80% will be a mild case, and the 13% will be severe, and the critical is around about 5%. So the majority of infections are mild, and this is the time course of the disease progression. And these are the cytokine storm, or we call it cytokine release syndrome, where the interleukins, interferon gamma, and this TNF alpha causes the injury to the lungs, which is the main cause of mortality. So these are the patient risk status and sign and symptoms. I'm not going in detail into the clinical ones. The diagnostic method for COVID-19, a reliable one is the chest X-ray. You can see the ground glass opacity is bilateral. And the only thing is that the chest X-ray is negative in the early phases of the disease. So it is peaked only 10 to 12 days following system onset. So it is not reliable to detect early cases. Another thing is the chest CT scan. can detect the early COVID-19 cases where, like the RT-PCR, when the RT-PCR test is negative, but if the clinical suspicion is high, we can do a CT scan for the diagnostic of COVID-19. We can see a peripheral distribution with a ground glass opacity with a fine radicular opacity. We can hardly find lymphadenopathy or pleural effusion in the CT scan. And the central and peripheral distribution is rare in COVID-19. So this is the chest CT of a typical COVID-19 case. So these are the laboratory findings, and these are the markers of severe survivors and non-survivor pattern. And here you can see the SARS infective period is even in the convalescence period. So these are the temporal changes in the laboratory markers from illness onset in patients hospitalized with COVID-19. You can see the survivors in blue and the non-survivors, the ill patients, in the red one. So the D-dimers, non-survivors, as well as the interleukin-6 and serum ferritin, and also the LDH. The only thing goes down is the lymphocytes. So these are the bad prognostic markers for a serious disease. When the patient progresses to renal failure or the high CRP, ferritin, D-dimer, and LDH, and high CPK, they all denotes a bad prognosis. And the lymphopenia, especially lymphocyte, neutrophil lymphocyte ratio more than 10 is a bad prognostic sign. You can see the critical patients have a highest mortality, but even the critical patients can recover. So as the mild cases can have a mortality rate also. So regarding about the future perspectives, now we are using cumbersome RT-PCR machines. Now we later of Abbott machines, which we can use in our clinics, where the turnaround is around about 15 minutes for a positive case and 13 minutes for negative case. So these are the diversity of point of care products available at the moment for various diseases. What is exciting is in the pipeline, we will have more and more point of care or rapid diagnostic tests compared to the cumbersome RT-PCR machines, which is very expensive to install, and then the test cost is very high. We will have a very cheap, reliable test in the near future. But one thing to remind you is that this is the sensitivity and specificity rapid diagnostic kits on the market approved by US FDA for the emergency use approval. Here you can see the sensitivity and specificity almost about 100%. But when we actually use this, there are potential accuracy issues. And it is not surprising because we have found the virus only a few months ago, and because of we can sequence the genome, we can have these variety of tests in a very short time. So, and because of the emergency situation, there's no time for clinical validity. So with the technical validity, the US FDA has issued this emergency usage of these tests. So I would like to conclude that the samples, the results are as good as the way you have handled it. Because, as you have known, the coronavirus is a very delicate method, restoration, the storage, the transport. We must have a stringent guidelines. Otherwise, the test results will be, we will have a false results. And then, as we are having these kind of point of care tests, nations should have their own testing policy, especially when they are going to open up the lockdown. We have to test as much as we can so that we can stop the disease from the source of infection. So, as WHO has said, test, 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 test. And I would like to reference the California Governor, Mike Garvin. You see, the data is limited to that sample. And it's one thing to have the data, and it's another to do something with it. So, one thing good about this COVID-19. So, I'm optimistic. So now scientists are in the focus of great amount of research in the infectious disease, point of care, diagnostic. Now they are emphasizing on the COVID-19. But further on, I think these technologies we can apply to other diseases, especially for us in combating hepatitis viruses, especially the B and C. And these are my references. And thank you very much for your kind attendance. Thank you very much. I would like to hand back the floor back to the moderators. Professor Anil, please.
Thank you, Professor Nang and Dr. Soitung. It was an extremely meticulous presentation by both the speakers from Myanmar. They clearly and very eloquently told us what the virus is, how does it affect the various parts of the body, leading to inflammatory syndrome affecting almost all parts of the body, and what are the limitations in diagnosis, and what should be and how should we interpret. With that much of the knowledge, I think it is, as hepatologist community, it is our duty to understand from one of the most celebrated hepatologists of US, Professor Sanjay Satpathy, who not only has been through the thick and thin of dealing with such patients, but he has good number of publications. Sanjay is also collecting large amount of the data on the intricacies of the relationship between the virus and liver disease. Since he is directly involved with this patient, I think we will have never a better person to talk about the relationship between the liver and the COVID-19 infection. Professor Sanjay Satpathy, please.
Thank you, Professor Anil Arora, for the kind introduction. Good morning to my colleagues from United States, and a good evening to my colleagues from India and Myanmar. It's a pleasure to be part of this academic endeavors, and I've been assigned to talk on liver and GI manifestations of COVID-19, which I'll take you through in the next 15 to 20 minutes. I have no actual or potential conflict of interest in relation to this program or presentations. So to begin, I would highlight this slide, as always I have done it, that how rapidly this disease has progressed. When the first case of the coronavirus was reported from the Hubei province of Wuhan in China, and then WHO declared a global public health emergency in January 30th, 2020, and since that, this journey has become really an ordeal throughout the world. As of now, about 4 million cases of coronavirus has been reported, more than 200 countries across the world. Now, an interest for COVID-19 has been not only generated to those who are the frontliners, those who are in the emergency room directly dealing with these cases, who are specifically the symptoms related to the upper respiratory or the lower respiratory symptoms, but manifestations are related to multiple organ involvements because of what Professor Winaying has already and the other speakers has already reported in details. My focus will be on the gastrointestinal and liver manifestations. Also, I would like to highlight that the manifestations are not just pulmonary. There are several other extra pulmonary organs that are involved, like cardiovascular systems, hematologic manifestations, immunological manifestations has all been very well described and beyond the scope of my discussion today. But just want to highlight that acute kidney injury also occurs in about 25 to 29% of the critically ill and deceased cases from Wuhan that has been reported. So another important findings that we have observed in this group of patients. Now my focus would be COVID-19 and liver disease to begin with, and then we will switch our gear towards GI manifestations. There are three areas that I would like to cover. First, I would like to highlight that there are several unknowns and several speculations about what's the relationship of COVID-19 and liver manifestations. So whether liver test alterations are a sign of pre-existing liver diseases in patients with a more severe course of infection. Why is moving on? Or whether they rather reflect a liver damage caused by the virus itself, or whether they mirror a severe inflammatory response, or whether the acute liver injury portends to a poor prognosis. These are the areas that we'll be talking about. So the first question is whether liver test alterations are a sign of a pre-existing liver disease in a patient with a more severe course of infection. As of now, there are several series of cases that have been reported throughout the world. And what we know is that the presence of pre-existing liver disease has been very small. So although there is speculation that these reported cases may have not been diagnosed because of the severity of their illness, whether they have underlying chronic liver disease may not have been fully reported, but known liver disease, it seems like ranges from 3.2% to the range of about 11%. So certainly this would not be the cause of severe liver injury manifestation that has been reported in this, or the manifestation that has been reported in the proportion of liver injury that has been reported in this group of patients. Now let's see the largest series of cases that was reported in the JAMA from our own center, Northwell Health, where I am the medical director for the liver transplant program. And what we have seen or reported in this series of cases is that the liver test abnormalities are quite common. AST more than 40 was reported in 58.4%, and ALT more than 60 in 39%. So this is quite common to have. Again, if you raise the bar of this, the normal for AST and ALT, I'm pretty confident these numbers will go up significantly as well. I would go back to the study, the largest study that was published from China, 1,099 cases. And if you look for underlying chronic liver disease, especially hepatitis B, which is common in the Asia Pacific area, they have reported only 2.1% of their large series cases with hepatitis B. And when they graded the severity, looked based on the severity of the liver disease, about non-severe versus severe, and there is pretty much no significant difference, although the numbers are small, with regards to any association of severe presentation related to underlying chronic hepatitis B. Whether NAS or NAS-related cirrhosis patients are potentially at increased risk for severe clinical course. Well, if you look at the study from Northwell and the study from Cornell, both are from New York City, the prevalence of comorbidities or common comorbidities are quite likely related, quite common, particularly hypertension, 56%, obesity in 42%, and diabetes in almost 34% of these patients, and they're almost similar in the other study as well. So these are common comorbidities in patients with NAFL and NAS, and presumably NAFL NAS patients would be at increased risk because of the increased comorbidities to have more severe clinical course. Although studies with regards to this are still not enough to educate this relationship. Dr. Aurora's group has recently published a study in diabetes and metabolic syndrome. They found that diabetes mellitus is associated with increased mortality and severity with COVID-19 infection. And not only that, they also showed increased, not just severity, they also found increased mortality in their meta-analysis. So all these points that there is a caution that NAFLD-NAS patient may be at increased risk of having more severe clinical course and mortality. Now, one study specifically from China looked into this aspect, and they have a 202 patients, 76, that is 37.6% patients had NAFLD in that group. And what they have found that patients with NAFLD had a higher risk of disease progression, 44.7% versus 6.6%, and higher likelihood of abnormal liver function from admission to discharge, 70% versus 11.1%, and have a longer viral setting time compared to patients without NAFLD. So this kind of speculation generated based on the previous studies, as I mentioned, certainly looks like possibly NAFLD patients are at increased risk. Again, maybe related to their comorbidities. We do not know there is a direct relationship of NAFLD causing an increased liver injury in these patients. Now, the next, another study that also came from China, multi-center study, looking into the relationship between the symptom onset and they present an admission to the hospital and liver injury. And they found that a longer hospital, a longer course of symptoms would manifest with more higher degree of liver injury in those patients. But in the hospital, when they looked into patients who had liver injury versus no liver injury, they didn't find much a difference with regards to the number of days in the hospital. There was no difference in terms of the liver injury. Another question that was another question that they tried to answer in this study was specifically they looked at the characteristics of the liver test in the COVID-19 patients, a study from China. Again, 417 patients, and they found 76.3% has abnormal liver function. However, liver injury was reported in 21.5% of the patients. When they categorize these patients into severe versus non-severe disease, the patients with the severe disease have 46.2% had liver injury versus 14.4% who did not have severe liver injury. Again, patterns of liver injury has been reported in the same study, and they actually divided the groups into hepatocellular, cholestatic, and mixed pattern, depending on the combination of elevation of AST, ALT, and alkaline phosphatase level. What they have found, the mixed pattern of elevation is more common as compared to cholestatic and hepatocellular. And what in my clinical practice I have seen is that there is an AST predominant elevation as compared to ALT when they present in the hospital setting. Now the next question is whether liver injury rather reflect liver damage caused by the virus itself, whether the virus itself is cytopathic. Now let's look at the mechanism of action, which has been very well elegantly discussed by my previous speakers, but would just like to highlight one point, that this COVID-19, which is the spike proteins, requires an activation for attachment to the ACE2 receptors. And the ACE2 receptor, based on data from 2 independent cohorts, has revealed significant enrichment of the ACE2 expression in the cholangiocyte, 59.7% compared to hepatocytes, like 2.6%. So SARS coronavirus 2 might directly bind to the ACE2 positive cholangiocytes to dysregulate liver function. Although ACE2 is highly expressed in bile duct cells, this GGT was elevated in 54% of the COVID-19 patients, whereas only 1.8% patients had elevated ALP levels. So the question is whether is it the cholangiocytes related or cytopathic effect or not is not very clear, but certainly the ALP levels are not significantly elevated, questioning that whether the AS2 is the primary cause of the liver function test abnormalities or not. Now, I would like to highlight one case that was reported in American Journal of Gastroenterology. That was a case my colleague and from my center. This was a patient who had an HIV infection who presented with a dark urine to the emergency room. There's no respiratory symptoms and presentations, and had normal liver chemistries right with 2 weeks prior to hospital to presentation to the emergency room. When she presented to the ED, her bilirubin was normal, but AST and ALT levels were significantly elevated. AST 1230 and ALT 697, and a near normal ALP. So this patient, all the workups were negative for abnormal liver function tests. At that time, the suspicion for SARS coronavirus wasn't there in this patient on the day of admission because presentation was not respiratory, and she was saturating 94% in room air. Now, the next day, the patient started developing symptoms of respiratory symptoms, and there was suspicion of her coronavirus was raised, and she was found to be positive, and was treated with hydroxychloroquine at that time with a 5-day course. Over the course of the next 5 days, her liver function test improved significantly, and she was discharged home safely. So again, this patient raises the possibility that whether the virus itself can cause a direct cytopathic effect, because the patient did not really present with the respiratory symptoms at the beginning, but did have a primary presentation of abnormal liver function test. Another case, which is just published in Liver International, which is a publication from me. This is a 56-year-old woman who had a decompensated alcoholic cirrhosis, who has been abstinent from alcohol for about 3 months. She presented with abdominal pain, fever, and diarrhea, and was mildly hypotensive. It was hypotensive on hospital admission. She didn't have significant respiratory symptoms, and her INR was 1.9, and bilirubin was 9.4, alkaline phosphatase 128, AST/ALT were mildly elevated, AST 184 and ALT 94, about few days prior to the hospital admission. So this was the baseline. Now, on admission to the ED, what we noted, significant elevation of bilirubin to 14.5, AST 741 and ALT 241. And this patient was ruled out for other causes of abnormal liver function test. Alcohol level was negative, and the chest X-ray showed minimal infiltrate in the left lower chest. Otherwise, no respiratory symptoms. So we diagnosed this patient as acute or chronic liver failure, grade 2, and she was again positive for the SARS coronavirus by the nasopharyngeal swab. Again, highlighting that patients with underlying cirrhosis of the liver are at potentially increased risk of acute and chronic liver failure with SARS coronavirus infection. And this is the course of the patient during the hospital. As you can see, there was a significant spike in the AST and ALT, which improved over the course in the hospital, returning back to the baseline 2 weeks prior to the hospital admission, which she already had elevated liver tests. So having an underlying decompensated liver disease certainly can get worse, and may patient present with an acute and chronic liver failure, which you need to keep in mind. Now, another question is whether elevated liver enzymes mirror a severe inflammatory response. Does cytokine storm cause a bystander hepatitis in these patients? And this is a nice meta-analysis recently published by Lancet Gastroenterology and Hepatology, where they have looked into patients' liver enzymes or liver chemistries in comparing patients' severe versus non-severe disease. As you can see, the liver enzymes are favoring to be elevated in patients with COVID-19, especially the severe disease. So with the severe disease, they're more likely to have more severe liver chemistry abnormalities. So having discussed these cases and this discussion so far, I would like to summarize the mechanism of liver injury potentially causing abnormal liver chemistries in these patients. First thing is that a cytokine surge can cause, or the cytokine storm can cause bystander hepatitis. Second, there is a potential speculation that there could be a direct cytopathic injury to the hepatocytes. And third, the medications, many medications have been shown to potentially cause abnormal liver test in this group of patients. And hypoxia and ischemic liver injuries, again, in these patients are quite common. These are hypoxia-driven hypoxic hepatitis is well known to cause liver injury, and those should be kept in mind. That is, patients ventilated with severe respiratory distress syndrome also have significant increase in positive and expiratory pressure and increased right heart dysfunction, causing ischemic hepatitis as well in this group of patients. Now, just to summarize from this study that has been published, several studies, not going in detail, I did highlight it a little earlier as well. There is AST predominant elevation as compared to ALT, and which has been shown in a number of other studies as well. So as a general rule that I follow when I see a patient in the hospital, if a patient with a COVID-19 with elevated liver chemistries, I look for their patterns of liver injury. Is it AST predominant elevation or ALT predominant elevation? So if the AST predominant elevation and the bilirubin is less than 5 times, and alkaline phosphatase is not significantly elevated, less than 2 times, and the right setting, that is a high ferritin D dimer, procalcitonin, CRP, and LDH, I suspect this may be COVID-19 related, may be related to the cytokine surge, and I would observe this patient and treat the primary driving illness of this patient, which is the respiratory, and hope that once the respiratory illness is better, this COVID-19 related abnormal liver test will get better. Of course, this patient has underlying cirrhosis, then we need to monitor for acute and chronic liver failure. If there is no cirrhosis, I would expect a natural recovery with improvement in their COVID-19. But if there is an ALT predominant elevation, I would like to, or alkaline phosphatase is significantly elevated, bilirubin is more than 5, this may not be related to COVID-19, and I know Stella is moving out. And rule out non-COVID-19 related illness in these patients. If cirrhosis, then we monitor to assess their clinical course for acute and chronic liver failure. Now, next move to the GI manifestations. Now, is switching the gear from the liver to the GI, is the GI tract involved? So digestive tract is a site of expression and possible driver of disease severity and viral transmissions. GI tract harbors ACE2 receptor, the target for viral entry into the liver cells as well. High incidence of GI symptoms is reported in series of COVID-19 patients. Presence of viral RNA in the stool infected patient also has been reported, and their significance has not been very clear yet. There is this study from Wuhan, the retrospective study of 1,141 cases, reported 16% patients with the GI symptoms, mostly with nausea, diarrhea, abdominal pain. Similar reported prevalence of GI manifestation has been reported 48.5% from 99 patients from Hubei province of China. And the GI symptoms and severity has also been reported in 651 patients, 74, that is 11.4% presented with at least one GI symptoms, and 10.8% had pre-existing liver disease. The study from USA, nausea, vomiting in 10.3%, diarrhea in 10.3%, and abdominal pain in 8.8%, and loss of appetite in 25.3%. This is a significant finding. The loss of appetite may be an initial presentation in the large number of patients. We have to keep in mind about this. GI imaging has been in a study recently over a 2-week period, 54% have been shown to have bowel wall abnormalities, 31% on CT scan associated with ICU admission habit. The odds is almost 15.5. Nematosis, portal venous gas, and has been shown in this group of patients. Pathology in 2 showed ischemic enteritis and fibrin thrombi in the arterioles as well. So again, this has been increasingly an area of interest by the gastroenterologists about the GI manifestations in this group of patients. I would like to summarize this rapid review that was published by AGA as, with regards to the symptoms and what they have shown. The studies reported from China, and when they compared the studies reported outside China, studies from outside China has reported more GI symptoms as compared to China. But the prevalence has been, these symptoms has been from 7.8% to about 16.7%. I would like to highlight this study, which is also something that caught my attention, is that a patient who had GI symptoms, they have a smoldering disease, and their outcomes are better because if you see any GI symptoms, when they present 97% and absent 181, patients who had an absent GI symptoms are more likely to die and had more likely to have ICU admission. Again, this is a small study. And I would like to see more studies, because the other studies have reported with a more severe disease have more GI symptoms as well. So again, we need to kind of, I would like to put a word of caution, but however, this study is interesting, and certainly the key points from this particular study that I can summarize is that among patients meeting criteria for COVID-19 testing, those with GI symptoms, 70% are likely to be test positive, and the presence of GI symptoms which is associated with longer illness duration and lower rate of death during the short-term follow-up, and the presence of GI symptoms is predictive of COVID-19 positivity, and these symptoms may portend to a slower and less severe disease course. My final slide is a word about IBD. Over the course of this last few months, 639 cases has been reported from US, Europe, 200,000 cases, and 1 in 300 have IBD. 656 cases has been reported IBD with COVID-19. The actual 117 cases reported of IBD and COVID-19 out of that. So if you, from the 117 cases, 27 were hospitalized, 23%, and 2% with IBD with COVID-19 required ICU or ventilator. So the numbers are small. What we can conclude from this narrative description is that there is should we stop immunosuppressive treatment in hospitalized COVID-19? That's the question. And yes, we should not stop them, because the course of these patients are not been shown to have any different, even if this cases has been reported so far are small. And that's all to say. Thank you very much. I would now hand over to Dr. Arora for the next speaker.
Thank you, Professor Sanjay. It was a masterly disposition of a complex COVID-19 and the presence of the liver disease. I think what you have very aptly summarized is what is the etiopathogenesis of liver disease in patients with COVID-19 infection. Is it because of the multitude of the problem like hypoxia, pro-inflammatory states, hypotension, or drug-induced toxicity, or there is a direct relationship between the virus and the liver pathology? And also you have very aptly summarized the way we at the moment look at the liver disease management in patients with COVID-19. With that, I thank you. And now we go on to the last talk of today's session, and it will be delivered by Professor Robert Gish, who is one of the most updated and well-read hepatologists from San Francisco. And I think we are honored to have him, who is going to talk to us about the management of COVID-19 infection once the infection is established. What is the current pharmacotherapy, and if that is limited, what is the future of pharmacotherapy and pharmacotherapy and other modalities to combat this deadly menace of COVID-19? Professor Robert Gish, please.
Thank you, Anil. I'd like to thank the sponsors of this meeting and INEDSYS for setting this up, all my wonderful colleagues in Myanmar. I've done a number of these with Dr. Arora and Dr. Satapathy, and I'm going to review in the next 20 minutes, maybe a little bit less, treatment options for SARS-CoV-2. And in this talk, there's a number of slides, so I'm going to move quite quickly. These slides will be posted on my website and also on this website, and it'll be part of the presentation, so you can refer to a little bit more detail later. Thanks so much. There is hope for treating SARS-CoV-2, COVID-19. Let's get into where the optimism lies. A lot of research has gone into the source of these viruses. There's the human coronaviruses on the upper, and then the most recent animals, SARS, MERS, and SARS-CoV-2 on the lower side. And this also helps with developing research and treatment by knowing the animal sources and gene sequences. This gives you a little bit more information about potential targets and information about the open reading frames, nucleoproteins, the polymerase that are part of this virus. So we know a huge amount about this virus already. Fortunately, we've been having research for over 2 decades in the coronavirus space. One thing I'm going to start out with is this hypercoagulable states. As was emphasized in Dr. Sadapathi's talks, there's a difference between liver enzymes and liver function tests. Bilirubin and INR are our best liver function tests. And interestingly, if you look at the coagulation profile in SARS patients, SARS-CoV-2, these patients are actually hypercoagulable. There's a prothrombotic state. This can be picked up with thromboelastography or ROTEM technology. And anticoagulation is being considered for a subset of these patients to decrease the more severe manifestations of this disease. Because of modeling, X-ray crystallography, sequencing, and mass drug screening, we're going to move forward to a variety of different treatments quickly. And I'll be focusing on some of these, which are direct targeting antivirals, as well as others that modify the immune system or modify the inflammatory response. This gives you some information on drug targets, including blocking entry, potentially uncoding, blocking the polymerase, blocking messenger RNA, and blocking viral excretion. Also, there's drugs that modify the immune response, but don't directly influence viral replication. Looks like blocking the ACE receptor is not necessarily good or bad, although patients who are on ACE or ARB medications may have a slightly improved survival. But eventually we may actually have drugs that target these receptors and block either the protease or block the actual receptor binding and virus uptake. This is data showing that these patients may actually have a lower death rate, so stopping antihypertensives is not advised unless the patient is hypotensive or having specific complications. This is a compound, camosate mesylate, that exploits potential entry, and this is in clinical trials currently. This is actually a repurposed medication that's been around for quite some time. It's a potent protease inhibitor, so it'll block the first step in viral binding and potentially blocking entry. Lopinavir, ritonavir, there was some hope that this HIV drug combination might have an effect, but this is a negative trial that was published in New England Journal of Medicine. This is still part of the global WHO study, so there's more data that will emerge on this, but right now there's no new trials that I know of that are being initiated with this combination. It's quite a bit of information about lung injury and different treatments for lung injury. There's also other problems with using anti-inflammatory drugs such as corticosteroids. So specifically now, corticosteroid therapy is not advised for managing these patients unless there's adrenal insufficiency or they fit ARDS and steroid protocols that might be used in an ICU setting. Chloroquine and hydroxychloroquine have gotten a lot of attention thanks to the wonderful President of the United States, but I have to say at this time, the molecular characteristics are quite interesting in terms of changing cytokines, changing lysosome acidification and viral release, but we do not have any data that these drugs are working, and there was another alert that came out in the press yesterday about an increased mortality rate with these drugs and having to do with cardiac toxicity, prolonged QT, and cardiac events. So theoretically looks good, but it's always important to do randomized clinical control trials. And what do we have to lose? Well, we can lose lives by toxicity side effects of these. This is a chloroquine study that was halted over risk of fatal heart complications. This is another study that showed data about an increasing mortality rate with hydroxychloroquine at 2.6 fold adjusted hazard ratio. There are challenges with all these studies. Many of them are retrospective, so we need to have ones that cover both genders, that cover a broad range of ages. We need to make sure there's no drug-drug interactions that may be influencing the outcomes. There appears to be a drug interaction between hydroxychloroquine and azithromycin, probably through cytochrome P450. So we have to be quite cautious when we interpret these, but let's wait for prospective trials, controlled studies that actually are going to advise us on what the best treatment options are. A little bit more warnings about hydroxychloroquine and chloroquine COVID-19. As you know, there's even people have lost their governmental positions in the United States. Dr. Bright, who was leading the vaccine lab, because he was blocking information coming out on hydroxychloroquine, thinking about patient safety first. Dr. Bright's an exemplary individual. Prolonged QT intervals. Remember, these patients may have a cardiomyopathy from underlying liver disease or other reasons, maybe age-related. Then we have the problem of the direct cardiac toxicity from potentially ACE receptors. Then we have the prothrombotic state, and then you overlay a drug such as hydroxychloroquine that may actually change QT and cardiac conduction. This is a very interesting study that took place using high-dose famotidine, an H2 receptor antagonist, that showed improved survival. This is an intravenous form. It is a 4 to 5 times higher dose than you'd use for peptic disease, but there did appear to be a clinical benefit that was published recently in a preprint. So I think we should wait until we have a second study confirming this and determine what the mechanism would be. It may have to do with blocking viral uptake. A little bit more information on how virus binding takes place and viral uptake. And again, knowing these mechanisms of binding and viral entry will help us design better drugs. There's interesting data about tetracycline having a potential. Tetracycline is a broad-based antibacterial and having antiviral agents. Prospective trials with tetracycline are ongoing. It's not ready for prime time in the clinic, but please wait for this data. Tocilizumab is an IL-6 blocker that's been used in the intensive care unit setting. As you heard from our wonderful speaker about the inflammatory process that leads to ARDS, IL-1, IL-2, IL-6, TNF-alpha are all increased. And potentially by blocking this, we can decrease mortality, decrease ventilator time, improve or decrease hospitalization time. IL-1 and IL-1 receptor antagonists are also being looked at. Canakinumab and anakinra are being looked at in clinical trials currently. Regeneron is looking at sarilumab, another anti-inflammatory compound. It's a collaboration between Regeneron and Sanofi, again, anti-inflammatory. This has to do with clinical characteristics of patients who've recovered from COVID-19. There's a lot of research that's gone into neutralizing antibodies. I have to say at this time, neutralizing antibody profiles are just now being determined. It does look like there is some short-term immunity that may be antibody-based, but the innate and adaptive immune system are involved. There is some data that came out last night that appears that certain T-cell profiles are actually involved with protection after infection. You all probably heard about the U.S. aircraft carrier that was on Guam, where there was a large number of individuals who were infected on that aircraft carrier. It was clear today that a number of those individuals either were reinfected or relapsed, so protective immunity that's antibody-based is still under research and not specifically proven. There's one study that looked at using IVIG in combination with low molecular weight heparin. In combination therapy may be a major part of managing these patients. Going after the virus, going after inflammation, trying to enhance the immune system and using anticoagulants may be key parts of decreasing in-hospital mortality. A little bit more on convalescent plasma. This was used successfully in SARS, MERS, and also in the 2009 H1N1. As you recall, the H1N1 was the 1917 flu that went worldwide. In 2009, these convalescent plasma reduced viral load and, more importantly, decreased cytokine burden. There's some small studies that showed clinical improvement in some case series also, one with 10 patients, one with 5 patients. All the patients in these studies demonstrated improvement in clinical parameters, and 4 out of 8 of the mechanically ventilated patients were extubated. As you all recall from the literature, the mortality rate for mechanically ventilated patients runs 50 to 80%, and there were changes in inflammatory markers and improvement in lymphocyte count. So it looks like this immune plasma may be of clinical benefit. This is a negative study that didn't show any clinical improvement, but did show decreased viral shedding. So we have to be cautious about this very expensive technology until we understand neutralizing antibody. More recently, there's been huge news about the RNA-dependent RNA polymerase inhibitors, specifically remdesivir. I'll focus on that a little bit more today, although there has been one study with favipiravir that showed decreased viral shedding also, and maybe additional clinical improvement. But let's go to remdesivir, a drug developed by Gilead Sciences to combat Ebola. Didn't have much benefit there, but they had animal and laboratory data to show that remdesivir had an antiviral effect. It's broad-based for the coronaviruses. A little bit more on the mechanism of action, which you heard about before, but blocking the RNA-dependent RNA polymerase does 2 things. It can decrease, 1, viral shedding, and number 2, decrease viral protein production. So this is a broad-based antiviral therapy. This is the remdesivir efforts that took place between January and May. As you know, there's been a number of major advances, multiple studies, and the US EUA granted an accelerated approval, although it's emergency use approval awaiting full application. These are the different remdesivir studies that have taken place. There were 2 in China that were halted, so we're not completely clear on those studies. The first one had 453 patients targeted, but only 237 enrolled. The second had 308 targeted, but only 74 patients were enrolled. The NIH randomized double-blind study with over 1,000 patients included critically and severely ill patients and some moderately ill patients. And the key thing is this is really the data that we're going to look at in just a moment. This is the simple study that helped us decide that 5 days was equivalent to 10 days. This is very, very useful because of drug production, ramp up, and distribution. This means more patients can be treated. So I think this is a very, very useful study and helped us decide on treatment duration. There's more information on this slide for your review later. The NIAID study was looking at this remdesivir with a 200 milligram IV loading dose, 100 milligrams a day IV for 10 days also. And this is an adaptive study design, but the primary outcome that took place is highlighted here. So the interim study results that were published that led to the emergency approval from the FDA was a reduced time in the hospital, and also a reduced mortality rate numerically that nearly reached statistical significance at a p-value of 0.059. These 2 led to Gilead deciding to release this drug worldwide, and they are being released and given at no charge. So DSMB, overseeing the trial, thought that remdesivir was better than placebo, and from the primary endpoint, which is time to recovery, and 31% faster time to recovery. Lambda interferons being looked at. There's at least 5 clinical trials. This had data previously with hepatitis B, hepatitis C, and Delta, and SARS coronavirus, as well as influenza and other RNA viruses. So keep an eye on lambda interferon. There's also interferon alpha 2B studies that were recently started. So interferon, this may in some cases be pro-inflammatory, they also have an antiviral effect and eventually an anti-inflammatory effect as well. A little bit more data on lambda having an effect on SARS-CoV-1. Sofosbuvir, interestingly, and potentially in combination with ribavirin, may have an effect, and even tenofovir, a drug used for HIV and hepatitis B in vitro, has antiviral effects as well. This is a list of a variety of different agents, some directly antiviral on your left, two of which we talked about that are looking optimistic, remdesivir and favipiravir. There's a number of supportive agents that tend to be anti-inflammatory and may help our patients once they become quite ill. And then there's other repurposed medications that may be useful, such as ACE inhibitors. There was a warning about ibuprofen originally from the WHO that has been discounted, and patients should get acetaminophen up to standard doses, and nonsteroidals are deemed reasonably safe at moderate doses for patients and may actually help individual patients as well. IDSA comes out with rolling recommendations. I would advise you to take a look at these. They're basically saying wait for randomized clinical trials. These drugs should not be used in an uncontrolled, unmonitored setting. Lopinavir, ritonavir, gone. Hydroxychloroquine or chloroquine, almost gone. Major caution about drug-drug interactions. Let's wait for more information on favipiravir, and maybe time for a combination with favipiravir and remdesivir. Convalescent plasma, very expensive technology, may be useful in severely ill patients that are in the ICU, potentially those ventilated. We're waiting for more data on remdesivir, but right now this is being distributed globally to hopefully decrease mortality and shorten hospitalization time. You can see other talks on liver transplantation through this website. I'm not going into that in great detail, but there's excellent guidelines that have come out from EASL, AASLD, and other organizations in this space. APASL has also put out a series of presentations, lectures that are available online that also address transplant setting. Finally, I'm going to wrap up with vaccine development. I know we just have a few minutes left. This is a typical timeline for vaccine development, which usually stretches out over about 10 years. The fastest vaccine that's been developed to date is the mumps vaccine in 4 years. This is the accelerated approach that's been advocated by the US government, and a number of other countries worldwide are thinking about this accelerated approach, but there may be very significant safety issues when we take this rapid approach to a new technology and a new virus. Challenges of vaccine include production, distribution, cost, dosing, redose, safety, efficacy. Who are in the clinical trials? Is there an age and response that's related? Is there a hyper response after vaccination with a post-vaccine and viral exposure inflammatory response? So vaccine, a long way to go. BCG and the type of BCG vaccine also appears to decrease the severity of illness. More data to emerge on BCG information. This is the discussion about favipiravir. You can take a look at this information in the literature. And experimental treatments for favipiravir may be showing beneficial response. This is the cumulative positive rate or decreased rate of viral production with favipiravir. Chest CT is also improved. Finally, research pipeline, antibodies, direct antivirals, entry agents, vaccines, repurposed compounds, targeting RNA therapy with CRISPR, interfering RNAs may also be a benefit, and cell-based therapies, including stem cell therapies, are being looked at as well. Hyperbaric oxygen, very expensive technology, but has shown some clinical benefit for severely ill patients. Zinc may be a benefit also. You can take a look at the study and information about zinc with an antiviral effect. And vitamin D deficiency appears to worsen disease, so vitamin D supplementation is safe and may benefit your patients clinically. Thank you for having me. It looks like we're finishing right on time. Thanks everybody for an incredible organization and series of presentations.
As we have communicated in the chat box, we do not have enough time to go ahead with the Q&A because we don't want to be arrested. We are going back home because of the 10 p.m. curfew. And if I have to go summarize all the presentations, Dr. Winine has clearly illuminated about the pathogenesis, the virus entry pattern of the disease, and Professor Chosoton also clearly tell us the different diagnostic test systems, and very, very useful. Anil, could you summarize, wrap up the two US presenters presenting?
Yeah, I think we had excellent presentation from both the speakers from the US. Professor Sanjay Satpathy did tell us about the complex relationship between the COVID-19 and the liver, whether it is a cause or the effect, and how are they managing this complex situation in day-to-day basis. In addition, he also highlighted the different patterns of presentation in terms of GI manifestation and how to manage these patients with immunocompromised states, especially the subgroup of the patient with inflammatory bowel disease, what needs to be done in the era of the COVID-19 infection. Similarly, Professor Robert Gish, in his elegant presentation, did take us through the journey of the current, past, and the future directions of the pharmaceutical agents in management of COVID-19 infection, and did tell us the limitations. Other than the drug like remdesivir, there is nothing on horizon other than the plasma therapy, which can be of immediate use to us. As I said, it takes decades and ages before a vaccine is developed. So poor country like ours can only depend on vaccination, and hopefully it comes earlier than sooner. Thank you so much. With that, I think I thank my moderator colleague, Professor Kim, and the speakers, Dr. Sanjay Satpathy and Dr. Robert Gish. And I am extremely thankful to all the audience, which in spite of their tight schedule of extensive restriction outside their cozy places at home, to have come and joined. With that, I am extremely thankful to the organizers, especially the INEDSYS, for contributing to the cause of this discussion on COVID-19. Thank you and bye-bye.
Professor Sanjay and Professor Chosoton and the Professor Winai. But I think because of the time limitation, we have to stop here. Thank you all. Thank you. Bye-bye.